viewpoint of PBC, and then afterwards you are going to hear about the viewpoint more from an Eastern viewpoint about PBC. These are my disclosures. I'll start off with a patient case just so you can get a sense of what we're seeing in our practice in North America. This is a young woman, married, 2 children, and has persistent abnormal liver biochemistry. She's AMA positive and she's symptomatic. It's fatigue, brain fog, itch, and you could put a scale to that if you wished. And she has clearly therefore a diagnosis of PBC, AMA positive, cholestatic, no alternative etiology, and she's started on UDCA but remains symptomatic. When she comes to our program, you can see that it's not difficult to identify her cholestasis. So alkaline phosphatase is significantly elevated despite treatment with UDCA, doesn't appear to be cirrhotic, has a FibroScan reading of around 7.5 kilopascals. So there's some fibrosis, but not cirrhosis. For the theme of the day, it's all around autoimmunity. Okay? So in this disease, the archetypal autoimmune liver disease, we see some classical autoimmune antibody results. We'll focus just going down. Her ANA is centromere positive. So that's actually quite common in patients with primary biliary cholangitis to be anti-centromere positive. Okay? Her IgM is elevated. This is like a biliary epithelial irritability. And she has anti-mitochondrial antibodies. Surprisingly, the titer of autoantibodies does not appear to be important in the diagnosis of PBC. So it really does depend on your lab and which assays you use when you're interpreting the results. We then look at some second-line antibodies, which are anti-nuclear, and she's SP100 positive. So actually the diagnosis here is not difficult. So if we take a step back, when you're investigating someone who's got cholestatic serum liver tests, you're trying to think about where the etiology will lie. Where is the pathophysiological insult? Okay? And if you follow a journey from the hepatocyte all the way down to large bile ducts, you'll start to see the journey of where cholestasis appears. You can have pure cholestasis, which is all in the hepatocyte. That's the classical for drug-induced liver injury. So the hepatocyte is very sick, and then you're cholestatic. PBC is a ductopenic small bile duct lymphocytic cholangitis. So it's in that area. Okay? Sclerosing cholangitis, which is not as common here as it is in North America, is a medium to large bile duct disease. And then, of course, you've also got, you're going to learn about tomorrow, IgG4 disease, which is more like a steroid-responsive allergy against bile ducts. If we then divide up the causes of cholestasis, again, intrahepatic tends to include biliary versus hepatocellular, drug injury genetics versus autoimmune, and then extrahepatic, of course, it includes all of the features that we see with obstruction. We then use very simple markers in cholestasis to try and make the diagnosis. Surprisingly simple. You were just hearing about using genetics in celiac disease. Well, we're still focusing on using bile acids, liver enzymes, ALK phos, gamma GT, and bilirubin. Okay? And we see different patterns. So cholestasis does not only mean that you have to have ALK phos changes. If you have a hepatic cholestasis, again, intrahepatic, PFIC syndromes, you can have very high bile acids, but actually nearly normal gamma GT ALK phos. Whereas when you're into the cholangiocyte disorders, the cholangiopathies, the PBCs, the PSCs, the IgG4 disease, that's when we really are seeing significant elevations in ALK phos and gamma GT, and some transaminase activity, but not necessarily particularly high bile acids. I just did bile acids on somebody who's got quite high-risk PBC, and their bile acids are only 22. If you did bile acids on someone with Alagille syndrome, they'd be sky high. So lots of differences between the different diseases. So we start off with the AMA test. We make sure that it's in the context of no other systemic disorder. And if it's positive, we've made the diagnosis, and that works in 90% of the patients. If it's negative, we're going to use anti-nuclear antibodies. We're going to use specific assays for the anti-nuclear antibodies, and if they're positive, we're going to save the patient a liver biopsy. If they're negative, you're then going to work through your list, which is going to include large duct disease for MRI, liver biopsy, looking at small duct disease. Sometimes we'll do a colonoscopy looking for inflammatory bowel disease, and increasingly we're doing more and more genetic testing to diagnose genetic syndromes, PFIC 1, 2, 3, and the list goes on and on and on. So that takes us to PBC. So first described by dermatologists. So again, a theme of the day, cross specialists. Okay? But cholestasis is associated with hyperlipidemia, and the original descriptions in the 1850s of Addison and Gall were of women with xanthelasma, xanthoma. Okay? We make a diagnosis now based on mainly blood tests. We use liver biopsy only carefully. Okay? We assess the risk of disease, so we understand for the patient in front of us what is their journey going forward. Have they got low-risk disease or high-risk disease? Now this is the Western view. We've got Urso. OCA now has been withdrawn from the market in the US and Europe, so we're left with PPARs, and in North America, predominantly use of licensed PPARs, and you'll hear about repurposed PPARs from my colleague. Okay? Our treatment targets for this common rare disease, 1 in 1,000 women over the age of 40 live with PBC in North America. Our treatment targets are normal alk phos, normal bilirubin, and normal quality of life. Okay? That's to try and keep it simple. That's ideal. That doesn't mean that everyone has to get to ideal, but it does help you understand some simple messages for your patients. And then importantly is the symptom complex, and you'll be hearing also about itch, because these patients are symptomatic, and the symptoms are complex. And you've already heard about some of the symptoms when the meeting opened this morning around some of the links between rheumatology and GI, where our patients have also got pruritus, fatigue, and Sicca complex as some of their symptoms. Now, in Ontario, we did some epidemiology. I'll be interested to know what's happening in Taiwan, but here we have in Canada about 2 per 100,000 per year people living with PBC. Okay? So that's not ultra rare, but it's not ultra common. 1 in 1,000 women over the age of 40. What we see, which is quite interesting, is that the male to female ratio changes with age, and when we're diagnosing men, we're diagnosing men who are older. Okay? So the men with PBC are older, the women are presenting slightly younger. Take home, around 1 in 4 of our patients are diagnosed before the age of 50, 3 out of 4 are diagnosed after the age of 40. And then prevalence is obviously sex specific, but overall is 20 per 100,000, but in women is closer to 300 to 400 per 100,000. So this is the disease, your healthy small bile ducts and your unhealthy bile ducts. Like many diseases, particularly autoimmune, it is a combination of genes and environment. Okay? The genes predispose to immunoregulatory loss. We heard about Tregs already today. The environment is the main trigger. We don't know the environmental trigger. Okay? We assume there's lots of environmental triggers, but it coalesces together to lead to a lymphocytic cholangitis that's then associated with leaky bile ducts and cholestasis. And paradoxically for this disease, although it's very autoimmune, our treatments are focused on the bile acid component, which is because the bile acids, when they leak out of the bile ducts, the small bile ducts, are so potent and are driving the damage, secondary biliary cirrhosis, and the journey. At a molecular level, what's driven some of our treatments is understanding it's a bile acid disorder, understanding more about how the gut and the liver, it's the wrong way around, the gut and the liver talk to each other, microbiome, bile acid recirculation, bile acid signaling through the FGF19 FXR pathway or FXI FGF19 pathway, controlling homeostasis of lipid metabolism and bile acid transport, versus the PPARs, which are nuclear receptors in the hepatocyte, which are also particularly important in the control of lipids and the export of bile acids into the bile canaliculus. And that's where our treatments have focused over the last sort of 8 years in terms of going forward. We are trying to be goal-oriented. So although when you have a rare disease, it's not the same as when you're managing a disease you know the cause, or a disease where it's very common and you've got very, very well-defined evidence-based guidelines. But in principle, we try and do the same for our patients. We're focused on their disease activity, their symptoms of liver biochemistry, the targets, which are simple, normal, alphos, bilirubin, and symptoms, okay, with the belief that that will lead to less liver transplantation. And in the West, liver transplantation remains in need for people with PBC. We are still transplanting patients with PBC because they seem to have disease that is sufficient that they end up with decompensated liver disease. So our patients have an aberrant cycle of inflammation, cholestasis, and fibrosis. We look at the liver enzymes. ALT, AST is not autoimmune hepatitis always, it can just be a cholestatic reaction. Alphos and bilirubin, sometimes gamma GT. Platelets, spleen size, and liver stiffness. And then we're trying to prevent cancer. And we recognize that it's a progressive disease, and 50% of untreated patients will develop cirrhosis over 4 years. Okay? The symptoms are very relevant. And when you do a symptom survey, we asked 100 patients with PBC about itch, fatigue, and dryness, Sika complex. What we saw was that 2/3 had itch, half had fatigue, and half had some Sika complex. And 1 in 4 had moderate to severe itch, 1 in 3 had moderate to severe fatigue, and half had significant Sika. What we found interesting was that this dryness associated with the fatigue. And in fact, that makes sense. If you're treating Sjögren's disease, there are now clinical trials of new drugs coming where fatigue is part of the assessment of drug efficacy. Disease severity need not associate with symptom severity. These were the questions about itch. Itch disturbed my sleep. I scratched so much I made my skin raw. I felt embarrassed because of the itching. And the itch scores do not correlate with the liver stiffness. This is a log scale. So you can have people who are very symptomatic, who've got early disease, and you can have people who've got late disease who are symptomatic. So there isn't a direct correlation. So how do we treat? Well, obviously we actually have very similar patterns of treatment in principle, okay? First of all patients get ursodeoxycholic acid. It's a bile acid pool modifier given in a weight-based manner, normally 13 to 15 milligrams per kilogram. And over many, many, many years, decades, we've been able to show that patients receiving urso do better than patients who are untreated. This is a global study, mainly Western patients, retrospective, but nevertheless, ursodeoxycholic acid makes you live longer. However, if you don't respond to urso optimally by blood tests, then you're on a journey to progressive disease. So in patients who've got elevated alkaline phosphatase or elevated bilirubin at 1 year, again using global cohorts, they have worse prognosis than patients who've got lower alphos. So this is the concept of surrogate endpoints and the concept of targeting biochemistry as our treatment goal. More so, we then looked at what happens if you have a normal bilirubin and you don't have a normal alphos. And we can show that the patients who did the best had a normal bilirubin and a normal alphos. So this may seem obvious that you want to have the best liver tests, But nevertheless, we were doing this for a reason, to try and help our guidelines and help our recommendations. So normal tests are our target. We're using liver stiffness more and more. We find FibroScan, we use EchoSense, FibroScan, but you could use Shearwave. It's a very good tool of liver health. It's a surrogate of fibrosis, cholestasis, and inflammation. It's not perfect. Okay, and this is a study recently published from the Global PBC Study Group that just shows that whether or not you have a biochemical response, you get extra information from measuring the liver stiffness. We measure the liver stiffness every 1 to 3 years, okay, and we recognize that the latest liver stiffness always gives you the most accurate prediction of what's going to happen to your patient. Okay, so biochemistry has significant prognostic ability. Liver stiffness adds to that. The next thing recently done from the Global PBC Study Group was to show that in second-line therapies, blood tests still help you prognosticate. So in URSO-treated patients, blood tests help you prognosticate. And now in this study from Roca, just presented at AASLD, these are patients who are on either a beta-cholic acid or a PPAR, bezafibrate mainly, okay? And in this cohort of patients, over 400, the patients who had a biochemical response on second-line therapy did better. So now we have validation that biochemistry works for URSO and biochemistry works for second-line therapy. So we look at the patient in front of us and we make an assessment of risk, okay? Are they lower risk or are they higher risk? The younger you are, the more your risk. The higher your blood test, the greater your risk. The higher your FibroScan, the greater your risks. This doesn't mean that you wouldn't treat every patient optimally, but it does mean that you focus your efforts on trying to get the patient with the highest risk onto treatment early to prevent them ever getting late-stage disease. In Canada, so this is the Western perspective, we have access to URSO. We still have access to beta-cholic acid, although that's not available in Europe or the US anymore. And we have 3 PPARs, and I'm going to talk about elafibranor and seladelpar, and you'll hear more about bezafibrate in the next talk about PBC. Okay? We have lots of symptom treatments, and I'll talk a little bit about new treatments that are coming. We recognize that the clinical trials are not perfect, the clinical trials are small, they are not head-to-head, they sometimes use different inclusion criteria. So when we talk about bezafibrate versus elafibranor, seladelpar, it has a different entry criteria for the clinical trials. But we have a beta-cholic acid, we have elafibranor, seladelpar, and there was going to be combination treatment where we put it all together. Okay? And we're looking at biochemical response, normalization, and we're looking at symptom control. To demonstrate that a beta-cholic acid was a drug that should be used, there was the phase 3 clinical trial where around 48% of patients respond, alk phos less than 1.67, 15% decline, normal bilirubin. We saw stability of alk phos, and then the hard part is how do you demonstrate survival in a very, very, very slowly progressive disease. This was improved survival against cohorts, but when you did the clinical trial, and the reason why a beta-cholic acid has had challenges, the randomized controlled clinical trial of a beta-cholic acid to prolong life did not work. There was not an improvement in outcome. But that's because very difficult study to do, very slowly progressive disease, patients don't want to be on placebo for 10 years or longer, and so it's very difficult to prove. And in fact, you'll hear a little bit about the proof of bezafibrate. It's probably also taken 25 years to prove. Other ways of doing it is real-world data. We hope that more real-world data will be used, and that's where you look at basically what's happening in your communities. This was synthetic real-world data where there's American patients given OCA versus patients who didn't, and it's a synthetic trial, and there was a suggestion that OCA made you live longer. So PPAR agonists are now really becoming more exciting and more in use. They've been used for a long time in Japan and also in France. They're different sorts. Bezafibrate is what's known as a pan-PPAR. Alpha, delta, gamma. It's micromolar EC50 in the laboratory. Elafibranor is more an alpha with some delta activity. Okay? And seladelpar is a delta. I don't have fenofibrate, and fenofibrate's a pure alpha. Okay, and that's the major differences between the agonists. They have different molecular